How many of you guys currently use echo encodes? Maybe a handful of the physicians. Anyone have ultrasound on the rigs that you guys are using for this kind of purpose? Not yet. And if we delve into it a little bit more, if only a little handful of our physicians that are in this very room use echo routinely for codes, what's our barrier? Why aren't we doing this a little bit more? Well, in 2017, there were two papers that both came out and said, if you used ultrasound encodes, you actually prolonged the duration of the pulse check pause. So if we think about it, doing ultrasound in the pulse check pause is the best time to do it because, you're not futzing around on the chest. Usually there's no one there. You got your 10 seconds. But both these papers independently said that if we do it, we're actually prolonging or almost doubling the pulse check pause to nearly 20 seconds. And if that happens, what are the ways we can combat it? Should we just abandon doing ultrasound encodes? So we know actually also that without ultrasound, we're going way beyond the 10-second mark. So even without something to worry about, we're not good at staying within the 10 seconds. So then one of the groups said, let me see if we can design a training protocol to implement ultrasound specifically during the kind of pulse check pause in a very systematic way and cut that time down. So they showed that they were able to cut down some time. They looked at ultrasound in the first pulse check for, tamponade, then RV strain, and then futility. The interesting thing was, though, that they found with some training, they were able to cut down the pulse check pause duration, but only by about 3.1 seconds. So that begs the question, should we still do this? Before we get started, I just wanted to go through a little bit of CPR mechanics, and this is what we're all taught to do in ACLS. Da-da-da, hands go there. And this kind of illustrates our predominant theory, at least in early CPR, which is the cardiac pump theory, as opposed to the intrathoracic theory. And the cardiac pump theory means that to achieve effective CPR, we're going to compress the ventricles between the sternum and the vertebrae. And that's how CPR works. Now, if I look at any CT image, any regular patient that might be getting a CT, and I draw a line between the sternum and the vertebrae, am I actually compressing the ventricle? I can't use my little pointer here, so I can't illustrate exactly where the ventricles are, but they're the big things, right? They're the two big chambers that's off to the left of the patient, actually. So, if this is the case in a majority of our patients, maybe the whole reason we're not getting enough better outcomes with out-of-hospital cardiac arrest is for a location reason, not a physiology reason, not because you're using mechanical versus manual compressions. Maybe our whole theory of why we do CPR is a little bit off. So for those of you guys who don't know echo, this is an echo looking at the heart. And for those of you guys who do know some views, I've put some very helpful markers to show you which view I'm trying to get. But the one that's moving right now is a 70-year-old who had a Lucas device on. By surface anatomy, it's perfect. It's right in the distal third of the sternum. And what am I seeing? The big thing, which is the left ventricle, is not being compressed at all. Instead, all the force is being directed over the right side of the heart and the aortic outflow tract. I'm using ultrasound here to determine whether we have good quality CPR ongoing, and there's not. So what should I do from here? We take off the Lucas device, start manual compressions in a position that's a little bit to the left of the sternum, in between the nipple line and the sternum, more on the left side, left ribs, if you will. And this is our next image. The big thing on the bottom is the left ventricle, and we go from seeing no compressions on the right to now seeing full compression activity on the left. And what I'm specifically looking for is full compression and full recoil, because that's how I know that there will be forward blood flow going to the brain and to the rest of the circulation. This person's end-tidal CO2 went from 18 to about 60 within seconds of me doing this. There are no large trials to study this. There's no large trials to study the outcomes of doing something like this, because it's really hard to do large-scale cardiac arrest research. But I hope it's coming, and I'll show you that in a few minutes. So this is a little bit more realistic. Instead of getting a lovely, pretty picture, this is kind of what we get a lot of the time. This is a 54-year-old guy with COPD who was talking with his mom half an hour before he went down. His mom heard a thud in the bedroom and found him on the floor. And they come in doing this. What's wrong here? Hey, how would you help these compressions out? Is there any depth, do you think, to those compressions? Too shallow. Also, the heart is being moved in a circular fashion, so it's actually being massaged around the chest. It's not being massaged into the chest. And so this is kind of what happens sometimes when you do the one-handed CPR with, like, in a half-assed way, you know? So we're like, okay, that's not effective at all. Now we're seeing a lot of artifact. It's kind of gray and like hazy, and that's because anytime you have someone with COPD or obesity, it just hides your good view. So that's why it looks kind of gray like that. So we direct the actual paramedic to perform better compressions, and we say go slower, go a little bit more to the left, and go deeper. And now, where there was some haziness before, I think on the large chamber that you see full compression and full recoil. Now with him, he had CPR ongoing about 40 minutes before he arrived to me. His end tidal was probably 13 or 14. He had a king airway in. As soon as we did this, within seconds, we had end tidal CO2s in the 80s. So we get ROSC, and unfortunately for this gentleman, because of the prolonged downtime, we saved him to brain death, essentially. So he became an organ donor and all that kind of thing in the ICU. But what if we were able to do this earlier? What if you guys out in the field could determine whether effective CPR was being given right then and there, deliver effective CPR for 45 minutes before me, and all I have to do is confirm it in the ED, and then we probably would have end tidals or even ROSC way sooner than the 45 to 50 minute time point. So as over the years, the benefit I've learned is that I can use echo during CPR to determine the quality and location of where I should compress. And those are the example on your right is a peristernal short view that's pretty not great because my LV isn't compressing at all, as opposed to the one on your left that's compressing fairly well. All right, how about this one? This is a 60-year-old. He has a Lucas device on. Good CPR or not good CPR? Okay, someone says no. How come? Why is it not good CPR? So someone said the outflow tract is being compressed. I don't know that I see that here, but what I do see is the heart is literally getting rocked side to side. So the Lucas is literally pushing and like a seesaw, tilting one end of the heart so that it just like seesaws back and forth without actual compression over the LV. Oakley dokley, so we know what to do now. We do manual compressions. We're now on the left side. I'm seeing more left-sided compressions there. And this is my first pulse check. Admittedly, it's probably a little hard to see, especially since we can't really dim the lights here. But is there any sustainable, life-sustaining cardiac rhythm there? Is it shockable? Dunno. Look carefully at, this is the mitral valve area, this is the wall, and you see how it's doing this shimmering thing? This is fine VFib or fine VTAC. Guess what shows up on the monitor? Nada. Either asystole or PEA. So if I didn't use ultrasound, you would look at the monitor and say, asystole, PEA, not shockable. When I look with ultrasound and I see this, I'm like, oh crap, that's actually fine VFib. That is shockable. Now you just discovered something that's shockable when everything else told you that it wasn't. So this guy ended up getting double sequential defib twice. Within 20 minutes, we have a beating heart that is a definite living sustainable rhythm back in NSR with amiodarone drips too. That's within 20 minutes. Went from dead to alive because we used ultrasound to guide our ACLS. This one was definitely a win. He survived to be neurologically intact about 14 days after his ICU stay. So benefit number 2 is we discover when shockable is deemed. Before, if you did your 12 lead or whatever, it was unshockable. These are a couple more examples, maybe a little bit better than the previous, where you can see more of that, fine VFib, fine VTAC motion. And we're looking for the whole mitral valve area to be fibrillating. And you can see the septum and the free walls all around the heart also doing the same thing. Anyone ever see that meme? Well, why not? I think we've come kind of full circle. So before, back in the 80s, basically if someone was dead, you shock them. Then it became this no-no thing to never ever do because you don't shock asystole. But for this very reason, maybe we should actually defib more than we are currently doing. I'm not exactly sure where this whole asystole PEA don't shock thing fits in the algorithm of ACLS anymore. So let's go through some whole cases. Hopefully people's minds aren't blown too much. 70-year-old, feels weak at church, has a history of an MI, and has risk factors like she was a prior smoker, feels unwell, faints onto a fellow churchgoer, and by the time EMS get there, she's in asystole. So what's going on here? CPR, right? This is with actually a Lucas device. Effective compressions or not? Understanding it's hard to tell. Yay, nay. I don't think it's bad, I think it's actually pretty good. Do I see a reason why this person might have coded? Okay, so, this won't go this way. This won't go this way either. Okay, so the liver's on top, and right underneath the liver, I see this gray thing. That gray thing could represent free fluid or clot, which means maybe tamponade. Okay, so I can't really tell too much information, so I'm going to do my first pulse check. Anyone see anything? Shockable, okay. So not only do I have something shockable, I have a reason for my code. This gray layer underneath the liver, that is actual clot. The clot is tamponading the right ventricle, so my right ventricle looks tiny. It's right on top of that big LV that's on the bottom of the screen. Okay, so if I've got clot and tamponade, what should I do next? needle it, try to suck it out. So we tried to suck this out. We didn't expect to get anything, but we actually got 60 cc's. And that is what we got after the pericardiocentesis. We continued ACLS, eventually got ROSC. And do you guys see a reason why this person tamponaded? So I'll tell you that the aortic outflow tract, which I can't really point to it here, the aortic outflow tract that's next to like the hands, that's enlarged. That means that the person probably had an aortic dissection that ruptured backwards, ripped something in the heart, leaked into the pericardial sac, and that's what caused her demise. Now here's the thing. If you are able to get an alive patient in that scenario, and you got a 12 lead on her, she may show STEMI in 2-3 AVF. So inferior lead STEMI is what might show up, because when it rips, it tends to rip the RCA before ripping backwards. So this lady was actually on her way to cath lab before she coded and came to the ED. Cath lab activation turned into ED resuscitation for aortic dissection, went to cardiothoracic surgery, got 70 units of blood, and she lived and walked out of the hospital. Pretty incredible from being dead to alive. And so now we see the power of being able to not only evaluate for CPR compression effectiveness, we can also evaluate for shockable versus not shockable, and the etiology of the arrest, all at the same time within a 5-minute or less time span. Pretty remarkable. Now, the thing I'll say about aortic dissections, I don't know how much the prevalence of it is here. At Yale New Haven Hospital, we almost see these like candy. I don't really know what's in our water, but I think we see the incidence of this is way higher than what it says in the textbook. And it's gotten to the point that we are training our PAs and even some NPs who work in our chest pain center to do this for every single one of our chest pain center patients, because we keep having disastrous dissections end up in stress testing. That's how common we are having it. So we're now instituting a protocol where we do this specifically for aortic dissection on all our chest pain center patients. There we go. Okay, what about this one? This is another 70-year-old guy this time, and he falls down, go boom, and EMS find him in asystole, so they start compressions. Any ideas about this code? Okay. First pulse check. Good cardiac activity or bad? Negligent, right? So there's negligible cardiac activity, okay. See a reason for the code? There's stuff, a bunch of stuff in a ventricle that there shouldn't be stuff in, all right? So up top by the hands, that is actually the right ventricle. The right ventricle looks pretty large. It's got a bunch of clot in it. And the LV is on the bottom. It looks smaller, and actually the septum is getting pushed into the LV. So until proven otherwise, this means there's acute right heart strain or a big-ass PE. Now, without getting in too much of the mechanics of it, we know that during ACLS, the RV will naturally dilate. When you get ROSC, it goes back to normal. So my question is this because ACLS has been ongoing, or is there truly a PE here? And the reason why I say it's a PE is because EMS were like literally almost on scene immediately and started CPR right away. And so I think it was less of a time issue, more of a acute right heart strain issue. So what should I do next? I know this isn't really being given on the rigs yet, but at least in the ED setting or even ICU setting, we give TPA, continue ACLS, and I don't really have a good life-sustaining rhythm yet, but I'm getting something back. That's about 15 minutes after we gave TPA. And this person is now on 3 pressors and being treated for the acute PE portion of their code. Dead to alive, you can't get more of a win than that. This, for those of you guys who don't know, this happens to be what it looks like when you get a clot in transit. So a clot that is going to become a PE very eminently. Part of it breaks off and goes into the lung, and so sometimes you catch these. How's this heart doing? So this person is also a cath lab activation, but stops in our ED because eventually he starts getting really, really, really bradycardic, passes out, and now has extreme symptomatic bradycardia. What should I do now? So we do some transcutaneous pacing to temporize for transvenous pacing. And we're like, wait a second here. Let me add some pressors. So I'm going to add either dobutamine or dopamine because they are inotropes. And when we do this, when we do the combination of that, we find out that one whole part of the left ventricle isn't moving. So this person has a big old MI, probably in the LAD region, because the whole free wall of that LV is taken out. And I only mention this because you can see this before troponin comes back, and sometimes before the EKG even shows a STEMI. So we now do a thing where if we have a great story, EKG is still ongoing, we will echo them right away to determine if they have focal wall motion abnormality, because cath lab will take these patients over and just someone who has a normal troponin without focal wall motion abnormalities. So we actually use this as a cath lab triaging tool. Okay. Just for those of you who are interested, this is logistically how we insert or help with transvenous pacing when everything's sterile. So the ultrasound person isn't necessarily having to be sterile. They just slide in underneath all the sterile stuff and help with some guidance there. So we're literally doing transvenous pacing without EKG. And we're watching the guide wire float into the RV. That has been described in the literature. Whoops. I still do the EKG when I can, but sometimes you just can't because of all the other stuff that's in the way. So this has become a favorite topic of mine, right? All that stuff I just said, that's all in the inpatient setting. But now what if we can have tools that brings this out to you guys, anyone working in the field? So we now have these tablet devices. They get pretty good quality now. There's me in the kind of like left corner there, giving some teleguidance. So basically, they call me and I can see their image on the tablet and they can see me. And I can take a pointer and be like, oh, look at this area. Or they can take their pointer and say, hey, what's this? So this is going to become a reality pretty soon. There's pretty awesome Italian med control setups where they literally have like 4 screens and one of those screens is dedicated to ultrasound. It's pretty incredible to see. This is the newest guy, and if anyone's interested, I brought it. So my little gadget here costs $2,000 plus a subscription fee, and hooks up to your iPhone or an iPad. That is me doing compressions using Butterfly. So the image quality is not as great as some of the images I showed you from a real machine, but if you know what you're doing, why not? You know, it's good enough. So this is going to become our reality, I think, very, very, very soon. Medical schools are already starting to deploy this all over. It's going to come to PA schools very quickly, as well as, hopefully, paramedic schools. So all this kind of stuff I showed you was really awesome, right? let's talk about some limitations into why it's really challenging to do. Sometimes, especially in larger people, this is what you get. And this is us trying to get a subxiphoid view, which is right here underneath the xiphoid process. And as someone compresses, your hand literally gets flown off. So it can be really hard to keep your hand there in the subxiphoid view. And that's another thing. So the other image is every time someone's compression happens, even if you're able to stay in one spot, you can't see anything. The picture goes away. And so I advocate for actually modified views. So I don't really like the subxiphoid view very much for CPR. I will get either a peristernal long or a modified apical as close to the Lucas piston or someone's heel of their hand as possible without interfering with CPR. The other thing is I throw a towel over the compressor's hands so that they don't slip in ultrasound gel. What does this mean for me? It means that I'm not waiting for the pulse check to get these images. To do compressions, I'm literally doing it as soon as the patient arrives in whatever position I can get to be on the chest wall without interfering with CPR. It means that I'm finding my views way before the pulse check, so when the pulse check happens, I know where I was and I can stay within the 10-second pause. Now we got to think about some room mechanics. This is an ideal, maybe there is no ideal, this is my made up ideal setup, just doing this. You got to think about which side do your techs like to compress on. Because if you actually look in all the ACLS textbooks, the compressor is always, or usually, on the patient's right, because they're right-handed. Like if you're right-handed, try this out for yourself. So I put my right hand on the bottom and my left hand on top, right? If I do it the other way, it feels a bit weird to me. And I bet you might find the same. So because we're using our right hand, it naturally almost always makes us go to the right side of the patient for some reason. I think it got ingrained to us from those ACLS textbooks. So if your patient comes in from the right, then if the ambulance comes in from the right, you might have to think about how you would modify this diagram. Then we got to think about where the respiratory tech is going to go, if you have residents or ancillary personnel, where they're going to go, and how we're going to effectively do a workflow of CPR given your room limitations. If you're out in the field by yourself, this all goes away. If you are, in your setting and you are a single provider with no ancillary help, this all goes away. So who's supposed to run the code, do the ultrasound, push the meds, give out orders all at the same time? You kind of have to figure it out yourself. And this whole thing has taught me how to kind of break it down like that. But you can do this if you're a single provider and comfortable enough with ultrasound to guide resuscitation with ultrasound instead of it being an adjunct. Anyway, just something to think about. Here's another thing. Okay, how is this hard? This is why it's really hard to do some research, because it turns out we can't agree on what is dead. Okay, I think we can all agree that this is dead, but what about that? Is that sustainable with life? Should I continue this code? I don't know. There's no right answers. There's no right answer here. So you could continue this code because there's a little something trying. What about the next one? I think that one looks a little bit deader to me than the previous one. This is actually what happens sometimes. You get a little motion when RT bags. So if you bag a patient, sometimes you get some valve motion. So I usually ask them to stop bagging for a second and see if that goes away. All right, enough about that, because we could talk about that for like a whole 45 minutes. You guys heard of EDs doing transesophageal echo for cardiac arrest? It's the newest thing. There is more than 20 sites that are now doing it. And it's because all those images I showed you, they are our best images, but frankly, it's hard to do transthoracic echo in coding patients. So a bunch of people said, okay, if we stick that thing that has a camera or a echo probe in it inside the esophagus, we'll get better views. And so I'm going to show you exactly the same things that some people have done with TEE, in that here's a transesophageal echo, my LV is that big, thick, muscular guy, my RV is the chamber next to it, and the RV is being compressed during CPR. Exactly what I just showed you, but from the inside. So there's more TEE literature that supports what I just said. That is also RV compression. So both these images show RV compression during CPR, so they need to modify their CPR. This is kind of like a more typical image of what you get sometimes with transthoracic echo, really grainy. So they're like, they got this, they're like, I guess we should continue. I can't really tell what's happening. I think this person's likely dead. So then they get the TEE and start realizing, oh crap, there's actually some motion there. Oh shoot, we should start CPR now. Right? So the quality, the image quality is what makes TE a lot better for us. Now, unfortunately for us, those probes are about $30,000 each. So it's a high bar, and this is why it's probably going to take about 50 years to make this standard. So now they're getting ROSC and continuing compressions. Do you think it'll ever come to the field? If EDs are starting to do this, then usually something filters out into the out-of-hospital world. And yes, it can. So last year, New Jersey EMS took a transesophageal echo out into the field. Yes, it was all physicians, it wasn't paramedics, but they actually reported it. So disposable TEE is coming your way. How quickly it's going to be adopted, I'm not sure, but you're going to intubate them anyway, usually. You've already, established the airway. If you do that, it's easy to sneak something into the esophagus. So maybe this will be a better thing to do in out-of-hospital rather than trying to learn with a butterfly. Who knows? We'll see. So in summary, all that stuff that I just presented isn't new. It's not really rocket science. But it really changed the way I thought about our AHA guidelines, how I think we get brainwashed into ACLS in one way because we all do it when we're very young without really thinking about it. And I really think it's time to rethink some of these guidelines and use ancillary resources to try to help us determine not only effective compressions, but effective location of compressions. And that often may not be where we think. We have a standard one-size-fits-all approach to death right now. We need to individualize death. And maybe that is what's going to cause us to have increased out-of-hospital arrest survival. So I hope these are food for thought. If you're interested in some of the references, you can QR code scan that thing. If anyone's going to ACEP in Denver, I'll be giving something similar to this and show more cases. And if my mom can do it, we all can. Thanks, guys.